Today, healthcare industry in India is growing very fast, and India is emerging as a hub for medical tourism. India has today a best of expertise, world-class infrastructure, and technology, but affordable healthcare and accessibility is a real challenge. Can a common man get a affordable treatment? The recent media reports, we all know healthcare in India cost is very high. The out-of-pocket expenditure is one of the highest in the world. As a national president, IMA, what is the view? What is the view how we can achieve affordable healthcare, which is universal access with accessibility to all in all the areas of our country? What are your views on that?
We need to understand with a different perspective. Most of the people are not aware. So IMA has brought out a scheme, jiska koi nahi uska IMA. That means that IMA doctors are supposed to guide the patients. For example, 30% of the population is BPL. 20 to 30% of the population is below poverty line. For BPL patients, there are N numbers of schemes available. We have RSBI, where 30,000, you have an insurance for 30,000 rupees, premium is paid by the state and by the center. Okay, so 30,000 is available to you. And among that scheme, there are hospitals on panel who are not supposed to charge you more. So therefore, within 30,000, you can get your treatment done. Then for BPL, there are many more schemes of the Pradhan Mantri where you can pay a premium of 12 rupees, premium of 200 rupees, and then you get so many other benefits. For BPL patients, you have private hospitals who are entitled for free land or subsidized land. They are supposed to see 10% of their indoor as free. So as far as BPL patients, you need to have your right. And for that, what happens is we don't go to vote. Your Mai-Baap is your councillor, your MLA, and your MP. And if you participate in voting, and if you know your rights, you need to go back to your councillor, guide me. Or you can go back to your family physician, guide me. So BPL patients, absolutely in India, is the richest healthcare person who receives the healthcare free of cost. Okay. Then in that BPL, there are 45 different categories, like rickshawala, like jhalliwala, like. So all those 45 categories also have benefits. So for all those people who have benefits, they are not aware of that. That's one. Two. Another 30% of the people today are working somewhere. They are working somewhere. And minimum staff in that working somewhere is 10. So therefore ESI is applicable. Then we go back to the owner and we say, Mera ESI mat kato. Remember, you only pay 1.5%. 4.5% is paid by the employer. For saving your 1.5%, you are saving 4.5% of the employer, and you are missing the benefit of ESI. And in ESI, even 20 lakhs treatment is free. So, and today the requirement of ESI is 20 or 25,000, but you have an option. Even if your income is more, you can insist on the ESI. So therefore, ESI should be compulsory. It is compulsory, but then as a public, we must ask for ESI and take benefits of ESI. So ESI will cover around 30% of the population. Okay, so the majority of the population is covered by these two things. The ESI and then comes his public sector. Totally free. Okay, then comes his CGHS. CGHS and their state equivalents. Huge population. Huge population. They have their benefits. They have free treatment available. They have free treatment available. People are not able to. So now you have to fight for your rights. That in CGHS, you start getting all your benefits together. And the CGHS treatment, you can get it in the private sector also. Now, apart from that, then comes in the segment who is middle class, who are not employees. Okay, now what are the options available with them? The first option available with them is whenever you go for a job, you insist on insurance with the employer. When you're giving me a salary of 25,000, give me 24,500 and pay my insurance. And now insurance companies are charging per month. They are no more charging a year. So you can pay up to 500 rupees a month and you can get a cover of 5 lakhs. And these 500 rupees you need to negotiate with the employer. So if I am going for a job, I am going to say, give me a job plus insurance. That should be your right. People are not insisting on that. So you start insisting that I will not do a job without an insurance cover. And that insurance cover should be monthly. Now, if you do a monthly cover, the person also will not leave you. If you pay his yearly, he may leave you after 2 months. So you say, I'll pay your monthly cover. So 400 rupees, 500 rupees is not a problem. Similarly, all those people who are employers, when they're doing of their employee, they're supposed to do it of themselves also. So insurance has to become a necessity. It is going to become a necessity of the population. Okay. Now again, a population will be there who is not insured. There will be who will be paying from their out of pocket. Yes. For those population, they have to understand that a government hospital, private room is the first option. So private treatment in a government hospital is the first option because they want a private treatment. And they must also understand that the government hospital is not for poor, it's for everybody. They can still go there. And if they don't get treatment there, they can get a letter and they can send the claim to the government later. As long as they have gone to the government and bed is not available. Because then there are schemes. Delhi Kalyan Samiti, Delhi Arogya Nidhi and Arogya Kosh. For citizens of Delhi, you can go to them. You must remember that heart attack treatment is free in every government hospital, including the stenting. With that. Now, those people who are still not, they want to go to the private sector, there are 3 options. First option is they can go to a trust hospital. St. Stephen's, Holy Family. Trust hospitals means that their land has been given free, so their rates are subsidized. They will be cheaper than the other people. Or they can go to doctors-owned nursing homes in residential areas. Because the land cost is not there, they are cheaper. Their services may be available at 25% of the cost in a corporate hospital. So you choose them. If you can't, then you can go to a nursing home which is not in a residential area, a commercial nursing home. And then you have a last resort to go to a corporate profitable hospital. Okay. Now these corporate profitable hospitals charges have to be compared with the charges of the US and the West, not with India. They will still be 1/3 the cost of the US. Say for example, if a private hospital is charging 50,000 rupees a day for an intensive care, the same charges in the US will be 2 lakhs a day. So this is meant for those people who otherwise were going to the US and spending 2 lakhs a day. Who can afford. It is not meant for other people with that. Now you also need to understand that whatever you pay in an intensive care, twice you will pay on the first day. 1.5 times you will pay if it is a ventilator care, and 2 times you will pay if the patient is serious. Because charges are more. Now today, for general public to afford that type of a hospital is impossible. Impossible. Because general public were in any way in the past also they were not going to US for treatment. Only a selected people were going. So the hospital like this so-called big hospitals who have the same facility as that of in the US and Europe are not made for those common men who are going to pay from their pocket. Unless the government subsidize the cost of the intensive care. So the time has come for the government. They don't have to subsidize, they don't have to open tertiary hospitals. Let them subsidize the intensive care facilities in various hospitals. Let the hospital say, let the government says that all ICUs in the city of Delhi will be subsidized by me and regulated by me. Today, government says we want to regulate them. Regulation will only come when there is a grant. Without a grant, government cannot regulate. The government can come back and say, we will give you this subsidy, and for that subsidy, you have to produce a subsidized treatment. I can understand. If you are not going to give that subsidy, there is no question of any regulation.
But Agarwal, this is very good one initiative you have informed. That is only, I think, available in Delhi. In a government hospital, if there is no facility available, or bed is not available, or particular test is not available, anyone can go to the private sector, and then government will do the reimbursement. But this is only, as far as my knowledge goes, only in Delhi.
No, when
what
you-
about rest of the countries?
See, the question is that somewhere it has to start. Delhi has started it. Okay, Delhi has done it from the Arogya Kosh and Arogya Nidhi and Arogya Kosh. They have using the same fund. There is a national Rashtriya Arogya Kosh and Rashtriya Arogya Nidhi. Okay, these funds are also available to other states. They can also do it. So somebody has to start. So this facility or this scheme which has started by Delhi, other states are also free to do that. Every state has a Prime Minister fund.
Yes.
They have a Chief Minister fund. Now these funds are for natural calamities. Whenever there is a natural calamity, they pay. Now, for example, there is a dengue death. Okay. Now, dengue has been declared by insurance company as a natural calamity, as an accident. So therefore, and dengue is a natural calamity. Dengue has occurred because the government has failed for the mosquito menace. Therefore, it's a natural calamity. Therefore, the payment of dengue, whether the patient is treated in the government or the private, should be done by the central or the state government. So this bill of 16 lakhs should have been billed to the government. When the government is billed, government will negotiate with the hospital whether I need to pay you how much. This controversy would have been over. Why everybody is saying is that you are charging 16 lakhs from a dengue patient. My question is, these 16 lakhs have to be paid by the government. And when they're paid by the government will come back and discuss whether it was overcharged or not. So any natural calamity, the debate is dengue a natural calamity? Answer is yes. Because this is because of a mosquito. Mosquito is not my production. Mosquito is because of the unhygienic conditions of the state. It's the responsibility of the state to look after the hygiene of the society. Therefore, it's a natural calamity. In a natural calamity, the payment has to be done either by the Chief Minister's Fund or the Prime Minister's Fund, as per the government policies.
So one method to make the healthcare affordable, you say, is insurance. Okay. What is your view on the healthcare spending in our country as a percentage of GDP? Because India is spending very, very less when we compare to overall expenditure being done annually. And all over the world, they say minimum 5 to 6% of GDP, healthcare expenditure should be that. And when it comes to when public funding is only less than 1%, or even 1.1%, what is your view on that?
My views are different from IMA views. IMA views are what you are speaking. But as KK Agarwal, my views are slightly different. Today, 1% is the government spending. Private spending is around 4%. So in total, around 5% of that is being done. And the government spending is also not 1%. It is disorganized 1%. Because if I combine the rural health, which goes to the rural ministry, environmental health budget, the water ministry budget, the surface transport ministry budget, the women and child development ministry budget, the budget in the military, if I combine all of them together, it will cost 3%. Because all military people health budget is not coming in Ministry of Health.
Yes.
Okay, all agriculture's health. If a villager dies in a hospital in the setting, the food crop, the food industry, the animal husbandry crop, the budget for the animal industry, the environmental. So if I take health of the environment, health of the animals, health of the plants, there are different budgets available. They are ultimately linked to health. water sanitation. Okay. Now this Swachh Bharat Abhiyan project, actually it is health, because you are reducing the incidence of communicable diseases. So therefore, surface transport (RTA). Okay, so practically the health budget is only for NCD, non-communicable diseases and cancer. All communicable diseases budget is available. Nutrition budgets are different.
Yes.
Okay, in pregnancy you have women and child development ministries looking after. Your Balwadi, Anganwadi budget is different. Your midday school budget is different. So I don't think so. But what is happening is there is a duplication of work.
Yes.
All the ministries are coordinated. The pharmaceutical budget is in the chemical fertilizers ministry. That's a separate budget altogether.
So if you combine all these,
If I combine all of them together,
sufficient.
it is sufficient for health of the people. But what is happening is they are working competitive to each other. They are not working in cohesive with consumer budget. When the health is a consumer, when I am in a Consumer Protection Act, that budget is also available to me. So every budget, petroleum, when you talk about pollution, the petroleum ministry comes in. If I need to tackle pollution-related disorders, I need to have a petroleum budget in the health budget to be considered in the health budget. But they are not working together. That's my personal opinion. Okay, though as an IMA we always say make 1 to 2%, but the government says when the health ministry we talk about make 1 to 2%. They say we are not being able to spend 1%. Why do we need 2%?
So besides this financial challenge, the other challenges for affordable healthcare we talk about is lack of doctors, paramedics, and nurses and other healthcare staff, and they say lack of even indigenous equipment. Today, our health industry, especially when we talk about emergency medicine or even ICU care, more than 70% of the equipment will depend on the import of equipments. So, what other steps we can take which contributes toward affordable healthcare?
I'll talk about three things. One of a need of investigations. We need to rationalize it. For example, why do you need 3 Tesla MRI in every center? Let in Delhi, in the city of Delhi, suppose there are 100 MRIs, let 90 of them with a single Tesla. Why do you need 3 Tesla everywhere? Then you are increasing the cost. Then you are increasing the cost to the patients. Why do you need? Why do you need a 64 CT? Let the person who is having a 64, 124 or 256 MRI CT scan do only coronary CT. Why are you doing the routine work? Routine work should not be required in those particular machines. Why do you require sophisticated machines? So that's one. To reduce the cost, there has to be a rationalization. Why should you use a heart hospital for doing a cesarean? Why should you use a heart hospital for doing a cholecystectomy? No. That means there are more number of hospitals. That's one. Two, number of doctors. I don't agree that there is a shortage of doctors. There is a reason for that. There is a reason for that. If there is a shortage of doctors, then the 16 lakhs bill of Fortis, doctors' bill would have been 4 lakhs or 5 lakhs. Doctors' bill was 3%. Okay, whenever there is a shortage or scarcity of a thing, that becomes costly. If the doctors are not there in the city of Delhi, then they will start charging 12,000, 15,000 per PS. That's the shortage of doctors. Today, doctors are available. They are basically available at 1,000, 2,000 rupees. But anywhere in the country.
But this is we're talking about Delhi example.
No, I'm anywhere in the country. Anywhere in the country. I'm coming to that. Anywhere in the country, doctors are available. Okay. Now, in a rural area, why doctors are in shortage? A rural doctor should be paid double the amount of a urban doctor because he's going in a difficult area. The salary of a resident in Delhi is 80,000. In a rural area is 20,000. That's not fair. That's not fair. I personally don't think so. There is a shortage of doctors. I personally don't think so. And the second thing is that there is a system of our doctors, of the technical doctors working in administration.
Yeah.
Is difficult.
This is a big challenge. Yeah.
That's a big challenge. Half of our doctors are not working.
Not any clinical work.
They are not doing a clinical work. Why physiologists, anatomists, pathologists are not in the clinical work? So you are basically not utilizing them. Third is that I want to differ slightly with Modi ji of Make in India. The Modi ji scheme should be cured in India. It should be a comprehensive. The campaign of the IMA is cured in India. That means our doctors are the best, our equipments are the best, our services are the best, our prevention is the best. The change, the modality in the medical profession should be cured in India. If I do the process of cure in India, then the government policy will be that only Indian stents will be permissible. Rest all they have to buy from their own pocket. You have Indian stents, you have Indian everything, you have Indian processes. The time you make that policy like China, that only Indian thing will be permissible, from tomorrow all the industries will come back in India. Even the foreign industries will start putting their plants in India and it will become cheaper. So that policy, that Indian drugs, why do you allow MNCs to be sold in India? Sell them, but then that will not be reimbursed. So CGHS reimbursement, Mediclaim reimbursement, Mediclaim can issue a notice today that we will not reimburse anything which is not available in India. That you have to buy from your own pocket. The cost of the healthcare will reduce by 50% from tomorrow. And when you have, today what happens is, the Indian stent company says, because our stents are not promoted, so we cannot bring new grants. For example, I start doing an innovation today, and I come out with a latest brand of stents today. And suppose nobody uses it, because the government is not pushing it. So next year, my stent will become outdated. I will not be able to bring a new stent because my market is not there. So therefore, when you have a cure in India concept, with that say for example, a person going to US for treatment will only be given a permission if the treatment is not available in India. So that is called as a program called Cure in India. Without that, we'll fail.
And what's the role of innovations and use of technology to make healthcare affordable?
I think the time is limited, and technology again has to be initiated and proposed, and it has to be promoted by the government in India, within India. And that innovations, number one is, say, in the field of medicines. You don't require Pentium, everybody doesn't require Pentium 7, Pentium 6. Our basic computers are okay. Similarly, new innovations are required by 10% of the society, not 100% of the society. So we need to indigenize innovations as much as possible, and that is only going to be possible with the China model, that in India we are going to promote things in India. That India is a force. All the other countries will be forced to bring their technology in India. The way China has progressed, the way Russia has progressed, the same methodology has to be used with that. As the time is less, the purpose of this program was the Fortis controversy, the Vedanta controversy, the Max controversy, and the whole hue and cry of the public. I can only tell you one thing is that I am also K.K. Agarwal, apart from Dr. K.K. Agarwal. When I go for my treatment, even I look for my budget. I see whether I can afford it or not. And I don't go to the hospital. I also ask how much it will cost me. I will also ask that is it within my budget or not. That's your responsibility. Don't say that we have full faith in doctors and doctors will decide my treatment. They are supposed to do that. They are supposed to do that. It's a joint responsibility. Patient and doctors need to sit together, and the job of the doctors is to look into the budget of the patient and help them in getting the treatment. That's all for today. Thank you, Dr. Kalra, for initiating this discussion, and I thought this discussion was the need of the hour. We'll come back with one more show next week. Thank you.